Danielle, student nurse practitioner with Northern Kentucky University, and I'm going to talk to you today about thoracentesis. So thoracentesis is a diagnostic or therapeutic procedure to remove fluid from the pleural space, which is the area between the lung and chest cavity. So anytime that you have a greater than 10 milliliter fluid accumulation in that pleural space, it's considered a pleural effusion. So conditions that could cause this are congestive heart failure, pulmonary embolism, pneumonia, viral disease, and pulmonary malignancy. So research indicated that conditions such as heart failure have increased mortality rate post-thoracentesis. So signs and symptoms of a pleural effusion could be generalized malaise, which is more common with a malignancy, pleuritic chest pain with inspiration, cough, tachypnea, dyspnea, hypoxemia, tactile fremitus, which can be felt, and also dullness to percussion. So if you have your hand on your patient's back, if you don't have ultrasound technology there, and there is a greater than 300 to 400 milliliters of fluid accumulation present, when you apply your hand to the patient and you're tapping on the area there, you're going to be able to hear the dullness to percussion. So also a deviation from the trachea away from the affected side, that would also be an indication of pleural effusion. So imaging to confirm the effusion, the imaging that can pick up the smallest amount of effusion would be an MRI, a CT, or an ultrasound. Those can all each pick up 100 milliliters of fluid, whereas your posterior anterior radiograph is going to detect it once it's reached 200 to 300 milliliters of fluid. Now, doing the lateral decubitus radiograph, that can detect a smaller amount than your posterior radiograph. So you need to educate your patient on possible risks that could happen with this procedure and obtain informed consent, written informed consent before proceeding. So risks related to the procedure could include inadvertent organ puncture, which could be to like the liver or spleen, infection, pneumothorax, hemopneumothorax, hemorrhage, hypotension, cough, pain, visceral injury, re-expansion, pulmonary edema, and just procedure failure itself. So with the discontinuation of the fluid drainage system, once you've reached 1,000 to 1,500 milliliters of fluid, discontinuing that at that point, slowly extracting that tube and drainage system will reduce the re-expansion pulmonary edema risk. Now, evidence has also indicated, evidence-based research, that ultrasound-guided techniques help reduce the incidence and risks and complications when using that technique when performing the thoracentesis. So also when doing the therapeutic thoracentesis, there has been studies that have shown that using the ultrasound-guided technique with that for patients with malignancies that are in a palliative care setting, it is shown beneficial for them. So you want to discuss with your patient their medical history, get a full H&P, talk to them about medications, disease processes, comorbidities that could increase the risk of complications during this procedure. You want to look at occupational exposures and symptoms they're having. Talk to them about medications that could cause a hypercoagulable state, looking at their INR levels, making sure that they're at 1.5 or less. You want to check hematocrit and platelet levels, making sure that if the platelets are less than 50,000, that you're talking about possibly doing a transfusion prior to doing this thoracentesis. So you're going to need a lot of equipment to perform this procedure. Hopefully your facility has a prepackaged thoracentesis kit. Otherwise, you need to collect up a sterile marking pen, gloves, drapes and towels, adhesive bandage solution, 4x4 gauze, sedative for the patient, a side table with a pillow, local anesthetic, medication, lidocaine, needles to administer the lidocaine, a 5 ml syringe, 25 gauge, 3 needles that are 20 to 22 gauge, 1.5 to 2 inches long, a 3-way stopcock, hemostatic clamps, pulse oximetry monitoring, a sterile 20 ml and a 50 ml syringe, 2 chemistry blood tubes, a 14 gauge needle, a 16 gauge catheter, vacutainers, pressure tubing, and just in case, you're going to want your ACLS equipment with a crash cart. You also want to have CBC tubes, anaerobic and anaerobic culture kits there to be able to send those when you're doing the diagnostic thoracentesis. So you want to check those for culture specimens, check for fungal and TB specimens. So you're also going to be looking at whether it's an exudate or transudate etiology. So you'll send those fluid samples and analyze them with the Lights criteria, looking at the total protein and LDH. You're going to measure and differentiate between those to be able to determine whether it's a transudate or exudate etiology. So now I'm going to have my patient come in. We're going to look at how the patient would be positioned. Patient, come in, have a seat. Here at the table, you're going to have signed consent. We're going to have cleansed your area with chlorhexidine. This is the area that we're going to be looking at here. Hopefully we have an ultrasound guided technique, and this process is sterile. We are going to use an anesthetic with lidocaine there to numb the top area before administering the 20 to 20 gauge needle down into the area to aspirate the pleural fluid. Now, if we're taking this to send this for diagnostic for pathology, we're going to connect our other syringes to that and then have that passively transfer into the culture bottles. If we're doing this here on this area for therapeutic purposes, we're going to have a stopcock on there and have that into a drainage system to be able to drain that 1,000 to 1,500 milliliters of fluid passively into our vacutainers. Post-procedure, we're going to slowly extract the needle. We're going to cover the area with a 4x4, and as we're doing that, we'll have the patient hum to have them have their breath out, and then cover that with an occlusive dressing. If needed, we'll do a post-procedure x-ray to check for pneumothorax. We're going to monitor their vitals, and we're going